Okay, great. All right, everyone, thank you for your patience. Let's go ahead and get started. Well, thank you so much for joining us again tonight, and welcome back to another session of Tea Time with an Epilepsy Specialist. For those of you that don't know me, my name is Rachel Stevens, and I'll be your host for this evening, along with Jesse, who is also on the call tonight. And we're so excited to have you join us, especially for our special edition this evening for Mother's Day. I'd like to remind everyone that this meeting is being recorded and will be reposted on our social media platforms. And just a quick reminder, when we get to the question and answer session for this evening, you can use the raise your hand feature. It looks like this to ask a question. If you have trouble finding it, that's okay. You can also submit your question into the chat and we can call on you after that. And we want to give a really big thank you to our sponsor this evening, Aquestive Therapeutics. We're so grateful for your sponsorship. And with that, I'd like to welcome Barbara Miller.
Thank you very much, Rachel. I really appreciate the opportunity to speak to you all tonight. And I really just want to say thank you very much for taking the time out of your busy schedule to join us all at Tea Time. Aquestive is very, very committed to the epilepsy community. Our quest is really advancing medications, solving therapeutic problems, and really improving lives for their patients and their caregivers. And we're very pleased to not only partner with physicians and healthcare providers and institutions, but we're also very excited to partner with institutions such as Epilepsy Florida. I think we all know how much they contribute to this community. And so I wanted to thank you again, and I was going to introduce you to our medical science liaison. You won't be seeing him tonight, but you will be hearing him. His name is Ayman Kamal, and he'll be going over a few slides, and then we're going to have the opportunity to hear a wonderful story from one of our moms.
Hello, good evening, everyone. Can you hear me?
Yes.
Excellent.
Yes.
Thank you, everyone, for the opportunity to present to you. My name is Ayman Kamal, and I am a medical affairs leader at Aquestive Therapeutic. Unfortunately, you won't be able to see me tonight because we had some technical difficulty. I just happened to realize the link wasn't working from Canada, and that's where I am today. Happened to be visiting some relative. But I am based in New Jersey in the US. So over the next few minutes, I'm going to walk you through some slides just to get you familiar with our company and also Clobazam, a new way of delivering Clobazam. So basically, so if we move on to the next slide, so why Aquestive is unique. We are a pharmaceutical company that advances and commercializes medicine to solve critical therapeutic problem and meaningfully improve people's lives. We apply innovative drug delivery technology and scientific expertise to redesign important medicine. Our initial focus is to improve medication and outcome for patients with central nervous system condition, including epilepsy. So the different delivery methods allow for the right amount of active pharmaceutical ingredient to get absorbed into the body at the right rate. So here on the slide, you see, there's three different ways: buccally delivery on the inside of the cheek, sublingual delivery under the tongue, and lingual delivery basically on the tongue. So we use a very unique technology, PharmFilm. It's designed for patients who may experience dosing challenges for traditional treatment. It's ideal for people with difficulty swallowing tablets. PharmFilm is a simple, non-invasive, convenient way to dose. on the next slide, please, this is a small video that really gonna walk you through and illustrate how farm film really works. Can you please turn on the video?
So Eamon, I'm pressing play, but it's not playing anything.
If you scroll down on the slide, you should see like a play pause.
Yeah, I see the play button and the volume button.
It's still not working?
No,
No.
no, unfortunately, I'm sorry. No, it's not playing.
It's not playing.
No. Do you want me to, is there a website that might have this that I can pull up for you, or do you want me to go to the next slide?
Yeah, I think we're going to move to the next slide. I'm not sure if the video is available on the website. It is available on YouTube, but maybe at the end of the presentation, I can quickly send you the link. Or maybe Barbara, in the meantime, if you don't mind looking for the link on YouTube, and we can play it after.
Okay, I'll go to the next.
Thank you. So
you're welcome.
Thank you. So we'll move on just for the sake of time. So we're here tonight really to talk about Clobazam. Clobazam is the first and only oral film formulation for Clobazam. It's important to know that Clobazam is indicated for the adjunctive treatment of seizure associated with Lennox-Gastaut syndrome in patients 2 years of age and older. It's a thin berry flavor film that adheres to the tongue and dissolves to deliver a full dose of Clobazam within seconds, really. So who is it designed for? Clobazam is designed for patients who really need an alternative formulation of Clobazam. For patients who may spit, drool, or have difficulty swallowing, or patients who have challenges consuming a full dose of Clobazam. Clobazam is really ideal for patients who need to reduce the volume of liquid, and we know that can be a challenge for many patients. If we move on to the next slide, please. So Clobazam is bioequivalent to Clobazam. Basically, we had to prove to the FDA that Clobazam is equivalent in terms of safety and efficacy to Clobazam tablet. So in order for us to prove equal safety and efficacy, we had to conduct a study, a clinical trial. So we basically compare Clobazam 10 and 20 milligram tablet with the Clobazam 10 and 20 milligram oral film. So what you see here on the slide, if you just eyeball the graph, you see that the line superimpose each other. So what this means is basically all the pharmacokinetic parameters were preserved. They're equal when you compare Clobazam and Clobazam tablet. So what does this mean is basically the way Clobazam and Clobazam tablet are absorbed, metabolized, eliminated very similarly. So based on that study, we were able to prove to the FDA that Clobazam is actually bioequivalent to Clobazam. The difference is the way it's administered. It's a different route of administration, which is more convenient for some patients who may have difficulty swallowing, or as I've mentioned before, patients who may have issue, spitting, drooling, or have difficulty swallowing a tablet. If we move on to the next slide, this is just to show you the different dose that Clobazam is available in. So Clobazam is available in a 5 milligram, 10 milligram, and 20 milligram. Simple administration in 3 convenient doses. Clobazam is dose proportional to Clobazam tablet, a 1-to-1 conversion. So what this means is basically you can convert from a Clobazam tablet to a Clobazam while remaining on the same dose. This is what we mean by a 1-to-1 conversion. Patients should be dosed according to body weight. Here you have a small table that really inform on how Sympazan should be dosed on weight. On the next slide, so how does it come? Sympazan is available. You know, it's individually wrapped in a child-resistant full pouch. Each pouch comes in a 60-count box, about 1 month supply, and it's ready to use right out of the package. It has a 2-year shelf life in a sealed pouch. It's easy to open, easy to administer. And that's really, I mean, my story tonight on Sympazan, and I am happy to take any question maybe at the end of the presentation.
Great. Thank you so much, Eamon. Thank you. And Barbara, I will let you introduce our guest speakers for tonight. Barbara?
Sorry, I was muted. I'm so sorry.
That's okay.
Sorry about that. All right.
That's okay.
So, our guest speakers, everyone, of course, knows Dr. Hind Kettani. She is board certified in both neurology and epilepsy by the American Board of Psychiatry and Neurology, and she's currently practicing at Advent Health Tampa. She is a member of the American Academy of Neurology and a member of the American Epilepsy Society, and she is currently active on the board of Epilepsy Florida. And our next special guest is Pat Dean, a nurse practitioner, and she's a clinical coordinator of the Comprehensive Epilepsy Center at Nicholas Children's Hospital in Miami. She received her BS in nursing from Downstate Medical Center and her master's of nursing from the University of Miami. Pat is nationally recognized for her work involving children with epilepsy and has been involved with the consumer side of epilepsy on local, state, and national levels. And she also serves as the president of Epilepsy Florida's board of directors. And last, but definitely not least, is Giulia Covella, a very special mom. She has been an epilepsy mom since 2017. She's also a stepmom and a fur baby dog mom. Giulia works in healthcare with the elderly. I'm very excited to have everybody here.
Thank you for having us.
Thank you. Thank you, Barbara. And Dr. Kettani, I'll let you share a few words before we hear from Giulia.
Okay. Well, welcome again, everybody, and happy late Mother's Day, but it's never late. And thank you for Barbara for sponsor our program. Thank you, Eamon, for the presentation. And thank you, Giulia, for being present and share with us your experience. And of course, a big thank you to famous Patricia Dean for being here today and for being so special, for being also very caring and a tireless advocate for epilepsy patients and their families. Thank you again.
Thank you. Pat, did you want to share any words before we hear from Giulia? You're on mute.
Obviously, I didn't want to share words.
Okay, I just wanted
anyway,
if you wanted to.
I just want to thank you all for coming, for joining us tonight. And I think it's what Giulia has to share is much more significant than any of us can share in healthcare. You know, it's one thing to have the privilege of taking care of patients with epilepsy, and it's another thing to be right in the thick of it and living it day to day and it being part of your life. And I think we have so much more to learn from her than anything I can say. So I'd like to go right to Giulia and talk about one of my favorite patients, Francesco.
Thank you, everyone. Good evening. I'm honored to be here and to have the opportunity to discuss our
our experience, and certainly many people on this Zoom have been part of our journey from early on, and we are grateful for them, because as the saying goes, it takes a village, especially when you have a child that's medically complex. It takes, I think, a county or a state. And we are very, very appreciative to Nicholas Children's, for sure, has been there since day one of Francesco's diagnosis. And Pat, of course, has been there, as well as the other nurse practitioners, physicians, nurses, techs, everyone at Nicholas Children's. We're very thankful to Epilepsy Florida. They've been, a partner, and have taught us a lot. And I know my husband and my family and friends share our gratitude to Aquestive, because Clobazam was a life-changing medication for our son, Francesco Torres. So Francesco began having just failure to thrive at an early age of 2 months. It was initially stated that he had reflux. He was having difficulty gaining weight, and was having continuous spit ups and reflux. And he began therapy due to torticollis. And my husband is a physician. He's a family practice physician for Baptist Health, and he just knew that something was wrong. He's also a father of 3 older children, Francesco's older brother and sisters, and he just knew something was just not right. He had his first seizure at 6 months, and shortly thereafter we went to Nicholas Children, where the amazing and late Dr. Bhatia, may he rest in peace, diagnosed him with a hypothalamic hamartoma. And obviously we realized that all these spit ups that he was having and all this failure to thrive was obviously associated to seizures. At the time, nobody knew. It is not a common diagnosis. Nobody knew that this was, that these were seizures. He was started on Keppra shortly, up during that admission, and seizures continued. He was having gelastic seizures that I'm sure many of you know sound like laughing episodes, but they're obviously seizures. And he continued to just be very delayed in his development. His quality of life was very poor. Pardon? Oh, sorry, I just heard somebody say something. It was decided surgical intervention was needed, and we went in for a resection with Dr. Bhatia in April of 2018. Certainly his quality of life improved. Dr. Bhatia and Dr. Miller, our neurologists at the time, were very helpful in guiding us through the process. And unfortunately, though, a few months later, the seizures returned. During this time, he was also started on Trileptal. And in the summer of 2018, his seizures worsened. He was having like tonic-clonic seizures every 24 hours. And I'm sure if there's any other parents on this call, or anybody who's had a loved one with seizures, you don't know if you're going to lose your loved one during one of those seizures, because even 30 seconds feel like 3 hours, especially when it's an infant, a toddler who can't speak for themselves. It's heart-wrenching. So it wasn't, I remember sitting in in December of 2018 in the office with Dr. Miller and Pilar. She's one of the nurse practitioners for the ketogenic clinic, which, by the way, we had tried ketogenic in the meantime, and it did not do anything for Francesco. I know it's been very good for other cases, but it did not help Francesco's case. And I just remember just uncontrollably crying because the seizures were just continuous. And they brought up Clobazam. We started 17th of 2018, and Francesco's last seizure was December 22nd of 2018. And knock on wood, and thank you, God, and thank you to whoever you pray to and believe in, Francesco has not had another seizure since then. His EEGs are obviously abnormal, and we know that he will always have the possibility of having another seizure. And we all know, he has his intellectual delay and other issues, but he has been seizure free. And we have Clobazam to thank for that. And of course, the amazing physicians and nurses and nurse practitioners and support system that we have. But that medication was a life changer for Francesco and for our family. That is for sure, certainly. He is still on Trileptal as well. We are now followed by the wonderful Dr. Fajardo, as Dr. Miller moved away and left Nicholas. And we're currently working on weaning off the Trileptal, just because we know that the Clobazam is really the MVP here in Francesco's seizure control. So that is our story, and there's a lot more that I could share. I could be here for days talking about it, but that's really the main gist of Francesco's story. And of course, our journey is long, and we continue to fight with him. And then we have our saying is fight for Francesco, and we've participated in the wonderful walks that hopefully we will be able to resume post the COVID madness one day, we hope. But we have an amazing support system around, and we look forward to continue to collaborate with Epilepsy Florida and anyone else to try to bring some meaning and something positive out of this experience.
Thank you so much, Giulia, for sharing that with us. I'm so happy to hear that he's doing better, and you are amazing, and he's so lucky to have you as well.
Thank
Pat
you.
yourself on the back, all of our moms on the call. I know it's not easy. I wanted to find out if we had any questions from any of our participants for Giulia or for any of our physicians on the call tonight. Not yet. Are there any other moms on that want to talk about their experience? Okay, well, we had some questions that were sent in that I can ask our lovely Dr. Kettani and Pat. One of those questions are, what percentage of children grow out of their epilepsy? And in these cases, is there a typical cause to begin with?
Would you like me to answer, or Pat, you want to take this one?
You can start. You can start, and I'll chime in if I think I have more to contribute.
Sure. Well, in children versus adults is two different entities of seizures that happen in both parties. And children, most of the time, not most of the time, but from certain age, from 0 to 10, we usually have a cause to their seizures. And if they have syndromes, like the case of Giulia's son, is a hamartoma. There is a lesion that is a focus for seizures. Therefore, the child has seizures. Unless the focus is removed, the medication is just treating, calming the seizures from reoccurring again. And Clobazam seems to have worked perfectly for the child. In some occasions, certain children don't have a cause for seizures, and either they have seizures they may outgrown of them, like absence seizures or other benign childhood epilepsy seizures. Then they can outgrow of them once they reach puberty or before puberty. Occasionally they don't, but their management is mainly medical. Then there is the other form of refractory epilepsies, which even 2 anti-seizure medication well chosen for the patient are not really controlling their seizures. I'm gonna let Pat maybe continue based on her experience, because she has more expertise with children.
Yeah, but thanks. I mean, Hind's right. And I think that when we look at numbers, I think it's probably close to 50% of children outgrow their tendency to have seizures. So I see some of these mothers on the call and they're saying 50%, you know, but there are a lot of children develop seizures and they're able to be controlled with meds. And one day they seem to go away as mysteriously as they came. And they're like, she talked about there's certain syndromes, like we call them benign Rolandic epilepsy or absence epilepsy of childhood. So there are a lot of people who do outgrow their tendency to have seizures. And it's just, they seem to be born with, for some reason, with this just genetic predisposition to have seizures. But then, you know, and there are a lot of children, though, who 50% of them who don't outgrow their seizures, and they can go well into adulthood with their seizures. And what we know about epilepsy is that there are a lot of different causes, right? Sometimes it's genetic, sometimes there's some kind of when the brains were developing in utero, something didn't quite develop properly, and that causes them to have seizures. Francesco had a lesion called the hypothalamic hamartoma. The hypothalamus is a part of the brain, and the hamartoma is a tumor. So that's what caused his seizures. But yeah, some kids have brain injuries in childhood, some have strokes. There are just a lot of different reasons why children have seizures.
Got it. Thank you. And we have a question from Donna Mack. You can unmute yourself, Donna, and ask the question.
Sorry, can you hear me?
We can hear you.
Okay, so I'm going to ask about Francesco, or if somebody else can answer too. I might say the medication wrong, the Zimpazan, what was the name of the medication that he was on?
Sympazan, yes.
Did that medication, is that what stopped his seizures, do you believe?
We certainly believe that. I'm not a physician, but the other medications did not make a dent, and it was 3 days after we started the Sympazan. And I know definitely the physicians would agree on Francesco's case. And my husband, I'm sure, agrees as well that was what stopped the seizures, certainly.
And this is question, but is that medication also used for a breakthrough seizure? Is it used like as an emergency medication? Do I have that wrong?
I can tell you in Francesco's case, that would be one of our rescue medications. Yes, according to what the neurologist has told us, that would be the initial rescue medication. And of course, we always have also the Ativan as the extreme rescue medication. But yes, an extra dose of Sympazan could be used as a rescue medication.
Okay, I think that's why I didn't realize it could be used as a sole medication too.
And any of the clinicians, if they want to correct me, but at least in Francesco's case, those are the instructions that we were given. But I don't want to give instructions for other children.
Well, Sympazan is a formulation of the drug Clobazam. It was being explained in the presentation earlier. So Clobazam is a drug it's from a family of drugs called benzodiazepam, right? So there's Clobazam, there's clonazepam, there's diazepam, there's lorazepam, and benzodiazepams are often used as rescue drugs for seizures, but they're also used. They can also, like Clobazam, is also used chronically to treat seizures. And was Sympazan the drug that stopped Francesco's seizures? I think so.
Okay, yes.
Having been on many meds prior to that, so yes.
I would agree with Pat too, and of course the mom who lived with the child at all time. That's probably the medication that helped. As far as rescue, because it's a long-acting benzodiazepine. Technically, it's not a rescue medication because the one with short action, they are the rescue ones, like Klonopin or Ativan or other short-acting benzodiazepine. Now,
But I think sometimes, Hind, I know Dr. Miller, and I know sometimes what doctors tell families is to take an extra dose of your chronic
yes,
medicine. And I think
absolutely.
that's what she means.
Yes, absolutely. Because there is a difference between when you have a seizure and you know your child is about to have more seizures and you give an extra dose than what is believed to be a rescue, like the Nasalam or the other new medication to break the cycle of a seizure. So therefore, it's a yes and no at the same time, depend how rescue is used. The term rescue is used, but it is a very powerful medication because it binds to the benzodiazepine receptors and it stays there for a long time compared to the other one that are short acting that are properly used as rescue medication. And then also, even when we have these long seizures are called status epilepticus, where can be very dangerous, the first medication we give is a benzodiazepine because we want to saturate these receptors to stop the seizures. And because it stays there longer, it prevents other seizures from coming.
Did that answer your question, Donna?
Yes, yes. I guess I believe we've used it for Riley for rescue. I just didn't realize that it could be used for seizures in general, but yes, that answers it.
Thank you. I saw your hands up, Kate. Did you still have a question?
Well, I don't know if I have a question or just, I have a daughter who is 17 and she got diagnosed with JME about 2 years ago. And just, we're struggling to have her kind of accept it. Along with COVID, she, she has bad mornings, what we call bad mornings, where she has kind of glitches. And then I've been telling her to go back to sleep, therefore she misses class, and then she gets really down on herself. And it's kind of a cycle because the stress, I know, is a trigger. But one of my questions was, do you ever, she's on lamotrigine 300, and we think that it's working really well, except for, a couple of bad mornings if she's very, very stressed or had a bad night's sleep. Do you ever recommend a very, very low dose of any anxiety medicine? She has test anxiety really bad. I was curious about that, if she's on lamotrigine. And then is there something anybody knows about a resource for her age group, so she could talk to other people? She feels kind of guilty because she knows she doesn't have it as bad as a lot of children do, or a lot of people do. But I think she feels very alone, and I guess we just don't really know. I feel like I have a resource now. I just, found this, but I don't know where she would go to try to.
Can I ask Kate a question? I'm sorry.
Yes.
Can I just, Kate, does your daughter go to public school?
She does.
So, now in the state of Florida, every public school does have a mental health counselor who's not the guidance counselor. And I just want to make sure that you're aware of that.
Thank you so much. She actually does have a counselor now. So we're still working on the anxiety, which I think is separate. And just, the acceptance. I think that if she had been diagnosed at a younger age, it might have been better, but hitting her smack in the teenage years, it's just, she's just having a hard time.
I get it. I totally understand, and I'm so sorry.
Yeah. Oh, thank you. In the school system, she has accommodations, but they're not like her neurologist is suggesting that she does not have to have a first period class. And I'm just wondering if this is normal for JME, just because the mornings are so difficult. We try to get her to bed at 10 o'clock, And some mornings, especially if she's on her cycle, she can wake up at 7 o'clock and, her hands will kind of shake a little bit. And she's like, I just think I need to go back to bed. And I'm like, fine. And she'll wake up at 9:30 and she's like, I feel so much better. So I don't know if that sounds normal.
Dr. Kettani can address the JME question, but I just want Ceci just posted in, did you post that in the chat, Ceci? We do have an adolescent group going on, Kate. So maybe you can get hooked
Yeah,
up.
we just started it. I was gonna let you know, but I was gonna let them answer your medical questions first, Kate.
Okay.
But we just started it. So I will put my contact information in the chat. If you would like to send me an email, and I'll make sure that you have all that information.
Okay,
and
thank
we can
you.
talk a little bit more about how Epilepsy Florida can support you guys, okay?
Okay, appreciate it.
Okay.
Can I just throw out a couple more suggestions on the education end of this?
Sure.
Because I don't know anything about medicine, but this is my wheelhouse. If she's on track for graduation, she might be able to have, well, she could probably get a senior privilege. I mean, it's late in the school year, but she can probably get a first period senior privilege next year.
Okay.
And if for some reason she can't do that, she might consider like her first academic class in the morning being a virtual class, like a Florida virtual school class, where, she isn't under the same kind of pressure to show up in a classroom and be performing academically first thing in the morning.
We're working on getting
fun.
letters from her doctor. The school, it's just complicated. The guidance counselor that she has is pretty slow. So we're working on that, hoping it's going to be easier than it sounds like it might be. But they said you're not allowed to just come in late at this point. So, I'm hoping it'll work out. It's just going to be a lot of paperwork. I think.
You're not allowed to just come in late, but if it's a medical issue,
Exactly.
it might become like an ADA thing.
Yeah. So like I said, we have the 504, but they're saying anyway. So I have to get letters, but I appreciate it, Ava.
Kate, I just wanted to let you know that Epilepsy Florida also has an epilepsy advocate that assists students that are having challenges in the school system, advocate for them, and also assist with those access programs as they go into, let's say, college or university or a tech school, depending on what it is, where we also have a youth advocacy council that your daughter seems to be the perfect age for. So we'll also provide you with information on that. We are here to help, and we do have staff that's experienced in this area. We do a lot of advocating for kids with epilepsy.
I really appreciate it. I think we've kind of been in denial. She's had 2 clonic tonic, the big ones. And we've been very blessed. They've been at home. And then we think she had one in the middle of the night after a very stressful event happened in her life. But other than that, I think we went a year without one, and I think we just kind of were in denial. So I appreciate y'all giving me some resources.
All right, we're here to help.
If I could say something, GME they have good prognosis. These are the kind of seizures that sometimes kids outgrow them. The problem is that the stigma of seizure exists at any age with anybody. Kids take it bad, adults take it bad, older people take it not in a good way, because society, unfortunately, is ignorance about the matter, and everybody likes to look cool, and we don't understand, and most of people are not empathic about it. Now, regarding the medication, she's probably seen by an epileptologist, and she's a good choice of medication, because Depakote is the first choice, but it won't be good for her because of her age. Therefore, if her medication is titrated up to a tolerated maximum dose that control completely her seizures, I do believe if she sleeps early, you try to avoid stress factors, change maybe a lifestyle modification, she could wake up as the other kids and go to school at the same time as the other kids. Because by her not attending the first period, we kind of engraven in her mind she is different, and she should act different, and therefore she will feel different, and that will grow up with her. I like to treat all patients, all people affected by anything in their life, as we are in 2021. We have many chance to treat many conditions that we couldn't handle before. But we don't focus on lifestyle modification because it seems so simple and so silly. But in fact, that's the most important and the first thing I will suggest to modify. And if if her anxiety level is high, probably she will need something to help her, like a small dose of antidepressant, like fluoxetine. It helps with stress and it helps set up the mood to a calmer level. Lamotrigine is also used as as a mood stabilizer. So therefore that should help as well. But I will insist mainly in lifestyle modification, which is not easy, but it's easier than her having to adopt a different lifestyle for a type of seizure that is not severe and make her feel she is disabled, because she is not.
I agree. Thank you so much. It's so hard to tell a 17-year-old about the lifestyle, but we're working on it.
Yes, but if it's not easy for you to talk about the lifestyle, maybe a healthcare professional can, and they'll have that conversation, because it's very hard again for a teenager to listen to their parents. I have teenagers as well, so I do understand.
I just want to verify, I don't want to take up the whole time. I just wanted to verify something real quick. Do you feel like I said, the 300 lamotrigine, she has one 100 pill and one 200 pill. I've heard, once we get much higher than that, she would have to add another medicine. And I just wanted to hold off as long as we could. So does that sound like a good, if she's doing the right things, that sounds like something she could stay on?
How much does she weigh?
She's like 5'5", 135 maybe.
And she takes 300 a day?
She does at night. It's extended release.
She takes extended release. I think we could increase a little bit if she can tolerate that, but maybe, how often she has seizures?
Not very often. I think that we're keeping them at bay by letting her say, if she has a bad morning, letting her, get enough sleep.
I will try to avoid that, and maybe if she doesn't tolerate a 50 milligram extra increase, if her provider agree to it, then they could add another medication. And I will strongly discourage Keppra, because she already has stress and anxiety, and that will just worsen that.
Okay, so
but
go
maybe
ahead.
if we add a little, if her provider likes to add a little dose of an antidepressant, a mild one, like a fluoxetine, the old one, they work really good for epilepsy.
Okay.
That could probably calm her, stabilize her mood, and maybe she doesn't need an increase in her medication or add in another medication.
Yeah. Okay. Thank you. We'll try getting her up in the morning, and yeah, I think it's that fear factor of, if we go ahead when she says she doesn't feel good, if she has a seizure, I'm going to feel guilty. She's going, it's kind of walking on eggshells, and she's a good kid. She's not lying to me. She honestly is afraid, I think, if she
But we should not reinforce that.
Okay. I'll work on that.
I think Kate, hooking her up with these other adolescents with epilepsy would really do a lot for her too.
I do too.
Sometimes she just might feel that she's alone.
Yes.
And if she meets other kids or talks to other kids online or wherever, however they're going to connect, that she might, it might really be helpful.
We will do it. Yeah, thank you. I really appreciate it.
All right, Ava.
Thank you.
Hi, how you doing? I have a comment about the last person and her 17-year-old daughter. What I found works for my daughter was with her taking the lamotrigine, is because she gets, when she gets angry, she has seizures. Number one, she's in anger management.
Okay.
And the thing that makes her angry are the children at school. And even with her being online, they make you do projects and things like that. together, and the children are rude. Let's just face it. So what's been working for her is we cut them in half. She takes lamotrigine when she first gets up in the morning with her Epidiolex, and then she takes lamotrigine before she goes to bed with her Ficumpa and her, what's the other one? Oh, Ficumpa, the lamotrigine, and the Epidiolex. So my thing is, yeah, it's extended release, but maybe the extension of it needs to be working more so during the morning. Start working in her system during the morning. Maybe cut it half and half. I don't know. But I know that, that's what worked for her, and she has been doing really well. And she's not taking, she's only taking like a quarter of what your daughter is taking.
Ava, I'm gonna say something. Any medication that is extended release, when you cut it in half, you kind of disrupt.
I don't mean cut it in half. Literally, what I mean when I say cut it in half is, I know that there's a certain amount that's supposed to be in your system at all times, but like if she started taking it in the morning opposed to at night.
Well, this is the thing, because with the extended release Lamictal, I agree with the concept you said, but I just wanted to correct something in case that's what is happening. If we split any medication that is extended release, we disrupt the molecules that are inside that pill. So therefore, it's better to take the extended release, a whole pill, even if it's a lesser dose, take it twice a day. Now, you made a very intelligent point. When you give an extended release medication, you don't allow the dip to happen with the extended release one time or the other medication. I prefer, honestly, before I switch to another medication or add another one, if there is a formulation that is extended release of the medication they already taken, I'll give them twice a day. So I have the full coverage, because it tells me that the brain doesn't tolerate any change.
Right.
So I totally agree with you. Maybe the option of having 150 in the morning, 200 at night, so we'll reach the 350, would be a good option for her. But we should never split that pill into half and half.
I didn't mean, that's what I meant when I said split in half. I meant
Yes.
150 in the morning and 150 at night. I'm sorry.
No, it's okay. Because even sometimes some other physicians, when they prescribe it, they say it's okay to split, but if you split it, then you lose the function of it.
Right.
But I think it's a brilliant idea and a great suggestion that if we could have it twice a day, also it will help, because the one that is taken at night is to prevent these morning jerky movements. And the other one will just keep maintaining that effect if it's taken again in the morning. Appreciate.
Thank you, Ava.
You're welcome.
We have just a few minutes left in our session this evening. I wanted to see if anybody else has any questions for Giulia and her son's journey that she shared with us.
I want to ask Giulia, because when did Francesco, I can't remember, did Francesco try a different formulation of Clobazam before he took the Sympazam, or did we prescribe Sympazam kind of immediately?
Yeah, no, it was the dissolvable film from the beginning, 5 milligrams.
Because I recently had an experience where, a mother was trying to give a 2-year-old, liquid Clobazam, and he kept spitting it out, and he couldn't take a pill, and he couldn't take, he couldn't tolerate the liquid. So we finally gave him the Sympazam, which made it a lot easier for both him and the mother,
Yeah.
So I don't know if we have any young, very young families on here like Francesco, but sometimes that's what makes Sympazam a good alternative, because these kids often, they can't swallow pills and they can't take liquid. So, the Sympazam helps that a lot.
And I actually did receive that video through YouTube, so I'm going to share it with you guys. Give me just a minute to pull it up. I did receive it from Eamon.
I want to ask a
Okay.
question.
Yes?
My son started having seizure when he was 18 years old. He's 32 years now. He's placed on Depakote and Phenobarb, but the increase in seizure, it is increasing, mostly at night. He has attack about 8 to 9 times a night. He's taking Depakote 500 mg and Phenobarb. He takes Phenobarb at night. But the seizure is increasing.
Have you
Has
spoken to their
his
doctor?
weight increased?
Pardon?
Has his weight increased?
He weighs about 55. 58.
Have you been to your doctor, his doctor?
Yes, and a neurologist is attending to him.
And what does your doctor say?
He says we should continue with the treatment. We have to go back for review. He has been on Phenobarb for long. He has just added the Depakote. At first, he was only on Phenobarb, but now he has added Depakote.
You know, it is very hard sometimes to answer this question because it would be completely wrong to give you a treatment advice based on a quick, like I want to say even a consult. Because
Yes.
first we need to know what type of seizure he has, how long he's been having them, the frequency, the intensity of these seizures. If he had previous MRIs, previous EEGs, what does it show? Are the seizures epileptic or non-epileptic? Has, like she brought up a very important point. Has he increased in weight? And we didn't judge the medication based on the weight. Is he taking the right amount for tolerated? And is it given at the same time every day? So there is a lot of questions that need to be addressed first before anybody can give you any advice. But the best way to address it, honestly, is to speak with the seizure specialist. If you don't get the help you need from a general neurologist, I think it's time to look for a seizure specialist and have a formal consult and ask all these questions. And now with COVID, we have virtual visits, so you could basically reach out to any epileptologist easier than before without having to travel far.
Okay.
You agree?
Thank you.
Can I suggest something else also?
Sure.
On every program that we have with Epilepsy Florida, I always tell everyone to keep a calendar. Write on the calendar if you get sick, if you feel sick, what time it was, how was he feeling sick? Did he get a migraine? Did he throw up? Anything that's repetitive, write it down. It could be the simplest thing is he keeps sneezing like 5 to 10 times in a row, nonstop. Write it down on the calendar. And then later on, he has a seizure. Does he blow up? Does he, you know what I'm saying? Does he get really mad and then go off and then go to sleep and then have a seizure? Write all of those things down in a calendar so that you can try to figure out what his triggers are. If you don't figure out what his triggers are, then you can't help him. You need to try to figure out the best way you can what his triggers are. I know what my daughter's triggers are: heat, anger, stress. So
Thank you,
keep her
Eva.
off the
That's
heat.
a good suggestion for everyone to keep a log of your seizures and any symptoms or anything in particular that day that you might be feeling. I'm going to share this video.
Okay.
Can you guys hear it?
No, we're not seeing it. All right.
You're not seeing it or hearing it?
Now we are seeing it. I wish I was.
Okay.
Push play. There's no sound.
Can you guys hear me?
We can hear
Yes,
you.
we can
But
hear
you couldn't hear the video?
Right.
Okay, I'm sorry about that. If anybody would like, I would be happy to share that video with you. It was the one from the presentation from Aquestive. I can send you the YouTube link, but we are out of time for tonight. I do want to say thank you so much to everyone that spent your time with us this evening for our Mother's Day edition of Tea Time. Thank you to Dr. Kettani. Thank you, Pat, for sharing your wisdom with us. Giulia, for sharing your experience and your journey, Francisco's journey. Again, a big thank you to our sponsor this evening, Aquestive, Barbara Miller, and Eamon. Thank you so much for sharing with us tonight as well.
Thank you, everyone.
Thank you. Have a wonderful night.
You
Thank
take
you,
care.
Giulia.
Thank you.
Thank you so much.
Good night, everyone. Thank you for
Good night.
the opportunity. Bye-bye.
Thank you, Julia, very much.
Bye. Pleasure, doctor.